For everybody that I haven't met, I'm Catherine Lee, and I'm one of the PGY3s in orthopedics here. And I'm going to start sharing my presentation, and we'll get started. All right, so in classic fashion, can anyone and everyone see this?
Yes.
Okay, perfect. Thanks, Dr. Mormon. All right, so I'm going to start our infection symposia by going through orthopedic infections, antibiotics, treatments, and delivery mechanisms. So we'll cover the anatomy of an infection, antibiotics, types and duration of treatment, and some talk about delivery devices. First, an overview. So we've all had this basic immunology book if you've been to college in the last 10 years or so. And classically, there are two arms of the human immune system, humoral and cell-mediated immunity. Humoral immunity, or antibody-mediated immunity, refers to antibody production, accessory processes like antibody formation, cytokine production, and memory cell generation. It also refers to the effector functions of antibodies, which include toxin and pathogen neutralization and complement activation, opsona, basically the sniffing dog watcher of the immune system. Cell-mediated immunity activates phagocytes and cytotoxic T cells and releases cytokines. They also trigger cell death and activate macrophages, natural killer cells, and cytokines to direct other cells. They are more effective in intracellular infections, cancers, and fungal infections. So if bacteria does go on to damage or infect a cell, what can happen can either be categorized as apoptosis or necrosis. And apoptosis is a form of cell death that is largely controlled by intracellular or extracellular mechanisms, but leads to a controlled resorption of cell parts by macrophages in a well-orchestrated fashion. Necrosis, on the contrary, is an unplanned explosion of the cell that results in spillage of intracellular contents. For a lot of intracellular bacteria, this allows spread and proliferation within the body. So as we can see here in the diagram, pathogen survival intracellularly here can happen if phagocytosis kind of doesn't happen with apoptosis. And then also, as kind of a reminder, there are gram-negative bacteria and gram-positive bacteria. Gram-negative bacteria refers to the gram stain in which, because of their robust cell wall, they do not retain the violet dye, and gram-positive bacteria obviously retain the violet dye. Gram-negative bacteria are generally more resistant to antibodies and antibiotics than gram-positive bacteria because they have an impermeable cell wall. The bacteria responsible for MRSA infections and acne are examples of gram-positive bacteria, whilst those responsible for Lyme disease and pneumonia are examples of gram-negative bacteria. So, over time, bacteria have also evolved methods of fighting back. One of the most commonly spoken about is the beta-lactamase enzyme in penicillin resistance. And there have also been other described methods, such as changing of target proteins, increasing production of outflow pumps, and changing the cell wall structure in general to limit penetrance. There have also been descriptions of quasi-dormant small colony variants of Staph aureus that actually live inside of osteocytes and inside of the osteocyte lacunae canalicular network. These Staph aureus bacteria get surrounded by this like dense mineral matrix of cortical bone, so they're inaccessible to immune cells, and they can live there for decades with a seemingly inexhaustible supply of nutrients, the same that end up feeding the osteocytes. And they also evade immune attack. They can also live intracellularly in osteoblasts, which are long-living, as we know, and can live decades within the same osteoblast undetected until awakening many years later. Bacteria can also develop in biofilms, which Dr. Seacrest will tell us all about later. But in terms of orthopedic implants and orthopedic infections, kind of the predominantly isolated bacteria from that part is like Staph aureus, Staph epidermidis, coagulase negative, Staphylococci, and Enterococcus. We also now know that biofilms can exist not just on implants, but as free-floating colonies that are also good at evading detection by our culture. So some common pathogens in implant infections, first and foremost, are the Staphylococcus species, MRSA, MSSA, Staph epidermidis, and other staph species like cons. These also tend to be part of like normal skin micro flora, but if they get in and create a quorum, so to speak, then they can have a real bad outcome. Enterobacteria like E. coli, Serratia, Proteus, and Klebsiella are also found. Some of these spread hematogenously. Enterococcus species and Pseudomonas, as well as Streptococcus species, are also found, although less common than Staphylococcus. And then anaerobics, most commonly C. acnes, formerly known as P. acnes, can also be found. So now that we've kind of gone over infection and kind of the etiology of those infections, we'll go over some common antibiotics. So the most common and the earliest found antibiotic are part of the beta-lactam family. They're a wide range of antibiotics that was first discovered by Alexander Fleming in 1928, and penicillin was, of course, the canonical bread mold antibiotic. All beta-lactam antibiotics have a beta-lactam ring, and they include penicillins and amoxicillins and cephalosporins like Anzef, Keflex. They work by interfering with the synthesis of peptidoglycan in the bacterial cell wall and are most commonly used against gram-positive bacteria. Bacteria have, however, developed resistance to beta-lactams via either the production of enzymes that break down the ring or efflux pumps. Next on the list is glycopeptides, which include the drug vancomycin. It is now become the first of the drugs of last resort when other antibiotics have failed. They are effective against MRSA and other infections, but recently there have been other newer antibiotics that have less resistance and I guess arguably more effectiveness against those infections. But nonetheless, vancomycin is kind of where we start. The bacteria against which the glycopeptide family are active against are somewhat limited, and they are, in the bacteriostatic category, which inhibit growth and reproduction. And these do so by inhibiting bacterial cell wall synthesis rather than a direct killing mechanism. In the sulfonamide section, we don't use a lot of sulfonamides because they have a lot of unwanted side effects like hepatotoxicity, but they kill the bacteria by inhibiting bacterial synthesis of vitamin B folate and preventing growth and reproduction. This is kind of the spectrum that we prescribe to all of our outpatients if we're not prescribing Keflex. And so kind of today, that's really all we use it for. The most recently discovered antibiotic is lipopeptides, and this is where daptomycin comes in, and they are bactericidal, which means they kill the bacteria that they come in contact with, and especially used against gram-positive bacteria. Daptomycin is kind of the most commonly used, and it disrupts the cell membrane in several aspects and thus killing the cell itself. There have been a couple of incidences where people have described resistance to daptomycin, but largely there's not been any kind of widespread resistance to it. And so just to kind of recap, there's a lot of antibiotics out there. I've circled some of them in red that we commonly use. Important to note that, they are categorized as bactericidal versus bacteriostatic. The effectiveness of either kind of largely depends on organism susceptibility though, and it's not kind of based on antibiotic mechanism of action. So this is the antibiogram for CMC main in patients, and this is kind of a test of antibiotics against the isolates found at CMC main for inpatients. There are different ones for ICU patients as well as MERCI patients, but in the gray boxes are kind of showing less than or equal to 60% susceptibility, and the black boxes are for either no in vivo activity, suboptimal clinical activity, or susceptibility testing not done. So as we can see, the methicillin susceptible Staph aureus species are generally pretty susceptible to all of the tested antibiotics other than erythromycin, and the MRSA clearly not, but in terms of mechanism of action, Bactrim is still pretty effective, as well as vancomycin, and then linezolid. Then here, Eric. Okay, here we go. So this is for the gram-negative organisms. Previously it was for gram-positives. And again, the grays are kind of less than or equal to 60% susceptibility to the antibiotic, and the black boxes are basically do not use this antibiotic for this. And we can see that E. coli is pretty susceptible to most antibiotics other than ampicillin and augmentin, and Pseudomonas is not, which we kind of already knew. This is the antibiogram for MRSI, pretty similar to CMC main in patients, and the gram-negatives at MRSI, again, pretty similar to the CMC in patients. But these are found on People Connect if you're ever wondering in general what to start a patient on before we hand it off to our infectious disease colleagues. So, and when we talk about antibiotics, we also talk about the duration of treatment. And, many consider that a prolonged course of 4 to 6 weeks of IV antibiotics is the gold standard treatment for bone and joint infections. But, there's also been some argument that maybe this practice derives from an era before we really studied pharmacokinetics, and that it may be a misconception that IV therapy is always stronger than oral therapy. So, as a result, though, of that kind of thinking, IV antibiotic therapy is often preferred to oral therapy and has been the standard of care for a lot of our non-acute infections. The OVIVA trial was a parallel group randomized 1-to-1 unblinded non-inferiority trial conducted at 30 hospitals in the UK under the NHS that tried to test whether oral versus IV antibiotics had any sort of difference in outcome at a year, and the results were ultimately published in the New England Journal of Medicine. They found that, when looking at the IV therapy group, prolonged IV therapy mandates placement of an IV access device like a PICC line, which carries complications such as catheter infections and thromboembolic disease. And, there was also increased costs with setting up outpatient antibiotic treatment and or infusion centers, or just hospitalization for the entire duration of the treatment, whether there was no OPAT service or the patient was just kind of not amenable to having a PICC line. Oral antibiotic therapy kind of mitigated those risks and was more convenient for the patient and less costly, but it also entirely depended on whether the patient was compliant with therapy and adherence to kind of the hourly dosages. They also had an increased risk of gastrointestinal intolerance and variable serum levels due to drug bioavailability. There was, however, reasonable evidence to support the effectiveness of the oral therapy despite other infectious processes that are traditionally treated with IV therapy despite these risks. And they had seen usage of this in the NHS system, oral antibiotics, for selected cases of bacterial endocarditis, MRSA skin and soft tissue infections, and febrile neutropenia. So they ultimately got about 1,000 patients, 500 or so in each group, and found that treatment failure at a year, which meant that they had to continue antibiotics or go on to a separate IND event, about 14.6% in IV therapy and 13.2% in the oral therapy group. They most commonly use glycopeptides or cephalosporins for the IV therapy, which is like vancomycin and Ancef or ceftriaxone. And then in the oral antibiotics, excluding rifampin, which they did not dose alone, were kind of quinolones or combination oral therapy. So this was kind of like the first large-scale trial to show that by and large, if an oral option is available, it may suffice for bone and joint infection treatment and decrease additional patient burden related to having IV medications in the long term. The same group is doing another randomized trial set to end in 2023, so they don't have the data published for that. But it's basically looking at how long do you need IV antibiotic therapy if you do the surgical IND or an explant or like hardware removal, and then place local antibiotics there for some duration of time of elution. And they defined orthopedic infection to include osteomyelitis, PJI, and fracture-related infection, as well as diabetic foot infection. So, when this data comes out, I think it can really have sort of guidance for us on it, because we're starting to put a lot of cement with antibiotic elution and antibiotic B, whether or not we need the traditional 4 to 6 weeks of IV treatment, or whether a short course of IV and then maybe transitioning to oral therapy or no kind of systemic therapy is sufficient. And so here are some other studies that determine are trying to determine optimal treatment duration. In the first study, this is a prospective, unmatched, unblinded, randomized interventional study to look at whether 4 weeks of IV antibiotics for PJI plus surgical removal of infected implant is sufficient, or whether they'd have to do the 6-week traditional IV course. And they showed that, 4 weeks is non-inferior. They also found data to support that there was no difference between early transition to oral from IV antibiotics, but the study was underpowered for that particular statement to make that definitive statement in this study. The next study, the second study, was regarding vertebral osteomyelitis, traditionally a kind of hard to eradicate smoldering infection that requires several months of antibiotic suppression. And this one showed that, about 92% of patients that were given antibiotics with a high oral bioavailability showed no difference in the distribution, or showed no difference in treatment, and that even the patients that were taken to 12 weeks of therapy were considered treated well before 12 weeks. They did, however, find that if the patient was older than 75 or had a Staph aureus infection like MRSA, it decreased treatment success. So now that we've kind of talked about how long do we need to have these antibiotics, we should talk about how to get them into the patient. Here are 2 ongoing trials with the metric group that are kind of studying, how to get these antibiotics in. The Vanco trial is in a phase 3 prospective randomized clinical trial to assess locally administered vancomycin powder to prevent surgical site infection after fracture surgery. And they are looking at adult patients with plateaus or pilons that get block randomized to get local or systemic vancomycin, and kind of look at they're also looking at, what species are causing these infections and the antibacterial susceptibilities amongst those patients that develop SSI. The PO versus IV study, which is another metric study, is a multi-center randomized trial to compare PO versus IV antibiotic therapy in post-op wound infections of extremity fractures. They're looking at adult patients who have culture-positive surgical site infections after ORIF, and they'll be randomly assigned to PO versus IV antibiotics. They are hoping to inform whether oral antibiotics is sufficient to treat SSI. So I think once the data is out for all of these, this will further guide us on how we can best treat our patients with, most efficacy, but also lower costs and better quality of life. So in this review, they summarize preventative, diagnostic, and therapeutic guidelines for infection after fracture fixation, which is different than a lot of the other studies that we've talked about, which concentrate on PJI, because I think the majority of orthopedic infection literature kind of is centered around hip and knee infections and how to treat those. Glaringly, the difference is that the hardware used for fracture fixation can be removed after osseous bridging. And a lot of times we're going for suppression until bone healing rather than eradication. But in general, the goal is surgical debridement as the first step after recognition of the infection. In this study, they looked at, what all of these groups did, and it was usually after surgical debridement, IV therapy was started to achieve rapid reduction of bacterial load at the site of infection. After 2 weeks of IV therapy, they tried to switch to an oral therapy with good bioavailability. But in the case of treatment with aim to cure the infection, total duration of treatment was about 6 weeks after removal of implants, or 12 weeks after if implants stay in place, or 12 weeks after determination of cure, so to speak. In the case of treatment with the aim of suppression, the duration of therapy was either timed for the fracture to stabilize or heal, and then 4 to 6 weeks after the implant removal after fracture healing, especially with high virulence infections like MRSA or like VRE. Local application of antibiotics has also gained traction due to the high local concentration with low systemic exposure for people who maybe have CKD or hepatic dysfunction. The downside of having cement is that once the antibiotics are eluted, the cement itself can also just be a surface for biofilm to form on. And studies that have been done on elution kinetics show that less than 10% of incorporated antibiotics will be released from the cement, and the time to elution may be in the timeline of like 7 to 10 days and not 7 to 10 weeks. Resorbable materials like calcium sulfate can carry a wider range of antibiotics than beads and don't necessarily need reoperation for removal, but they can ultimately end up in creating a serous fluid pocket or prolonged wound drainage as the beads sort of elute the antibiotics. So whether either is better for the situation they found was largely dependent on the type of wound and the type of implant being used. So in a different meta-analysis looking at implant design, they found that at the material level, composition of the implant has impact on bacterial colonization. In vivo, stainless steel is colonized more readily than titanium, perhaps due to the difference in osseointegration and protein absorption at the surface. They also found that in terms of hydrophobicity or hydrophilicity, hydrophobicity is definitely the way to go to prevent infection, and that surface composition and texturing all impact bone ingrowth and bacterial adhesion. And hydroxyapatite coatings on these implants may or may not be permissible for bacterial colonization, but they do help both bone ingrowth and you can couple like some antibiotics to them, like gentamicin, which can in the short term give you antibiotic prophylaxis. And this is all largely involved in what is the race for the surface, which is kind of cell ingrowth or bone cell ingrowth on the implant versus like bacterial and biofilm formation. And the goal being bone ingrowth before biofilm can form on there. A lot of these coatings can be either antibiotic releasing or non-releasing coatings. The general rule of thumb is that if it's a non-releasing coating like hydroxyapatite, it is applied by thermal processes, whereas antibiotic coated releasing surfaces are done by dip or spray coating due to their limited thermal stability. And they also briefly talked about nanotexturing as a way to foster drug delivery and bone ingrowth. And the effect of nanotexture on bacterial colonization has to depend on the size and the texture and the spacing of it. So they're still looking at it in a bunch of studies. There have also been current studies looking at peptide coatings as well as peptide antibiotic linked coatings and BMP coatings on implants, again, to induce faster bone ingrowth in the race for the surface. They've also looked at local deposition of antibiotics in bone cement, either as beads or spacers after implant removal into the infected cavity, as well as impregnating porous materials such as cancellous bone, collagen sponges, and other kind of bearing cements, with the goal that these elution systems will keep the implant surface sterile while eradicating bacterial contamination. Resorbable materials such as calcium sulfate beads can deposit high doses of local antibiotics, but are limited in their kind of time to elution as well as effectiveness, because certainly after implantation of a total joint, you don't want a seroma to surround the joint. They've also looked at silver coatings because silver has had success as wound healing dressings, and the silver does appear to decrease levels of adherent bacteria and bacteria adjacent to the implant, but whether or not there's long-term effectiveness is still to be studied. And I know that there are many antibiotic coated implants for fracture fixation as well as for joint replacement that are awaiting FDA approval, and it remains to be seen whether these implants will decrease the infection burden in the long term. What we do know, however, is that initial high local concentration of antibiotic is beneficial to eradicating resistant bacteria and biofilms. So high local concentrations facilitate diffusion to avascular or like watershed areas where diffusion via blood is not really accessible. So, we've looked at calcium sulfate and we've looked at PMMA, so traditionally your Palicos, your Simplex, things like that. And this basic science study out of Ohio State sought to test the levels of eluted antibiotics, which is vancomycin and tobramycin, in calcium sulfate and PMMA carriers on Staph aureus and Pseudomonas grown on agar gel. And they put them in little discs in the center of the Petri dishes, as you can see here. So when impregnated, the calcium sulfate beads in the short-term release and efficacy was greatly enhanced compared to the PMMA. And we can see here in terms of like how much antibiotic or how much bacteria is still left, because they did make the bacteria fluorescent, is that PMMA with just tobramycin and PMMA with just vancomycin had the kind of lowest bactericidal and bacterial static effects, whereas calcium sulfate by itself with tobramycin or vancomycin or combination therapy with vancomycin and tobramycin had the best effect. And they also found that, this was the effect of it was independent of loading density and not affected by exposure to body fluids. So just another thing to consider. So in conclusion, antibiotic choice is important. We need to look at susceptibility, but we also need to look at whether we need local versus local and systemic dosing. And, if there is an oral option possible, it may be better in some patients to treat them with the oral option so they're not hospitalized or they're not at risk for thromboembolic events. Delivery of antibiotics is variable. It is based on implant, it's based on the type of cement used, it's based on, the type of carrier used. And there are other innovations constantly being developed, whether it's hydrophobic coatings, silver coatings, variable texture implant coatings, or peptide or amino acid antibiotic coupling. So there's a lot that we will be learning in the next couple of years, especially with all of these trials concluding and hopefully the data being published there soon after. And so that concludes my portion of this talk. Does anybody have any questions?
Catherine, thanks for a great review. I would ask, has this changed our protocols any for like a trauma patient that comes in with an open fracture? I mean, do they get switched over to orals when they can take them, or are we still on our same algorithms that we've had over the years?
So I think that on the ground level, a lot of what has changed is that in the clinic, whenever patients come back with maybe some cellulitis or things like that, we've started them on oral antibiotics with the knowledge that, if it progresses or the oral medications do not eradicate it, we will refer them to infectious disease, but we've started first with like a Bactrim or a Keflex or things like that. As far as open fractures that roll in through CMC main, we do give them that like Q 8 hours of ANSEF until they get to surgery. And unless it's a case of very bad gross contamination, I think we generally stop the antibiotics at the 2 post-op doses and kind of consider our irrigation and debridement sufficient for that.
Yeah. Dr. Faring, do you have comments?
I do. Catherine, that was a great talk. It was very thorough, and I learned a lot. Can you give some recommendations on the truly penicillin allergic patient? Because that's always a question in the, at least in my elective practice.
So true penicillin allergy, and not just like intolerance to the medication, seems to be more rare than we think. And the crossover between penicillin allergy and kind of ANSEF allergy, it seems to be about, and I could be wrong, but the last time I read about it was like somewhere in like the 30% range. And I think a lot of patients get told, oh, I'm allergic to penicillin because my parents told me so, because 40 years ago I received it as a child. It's worth discussing with the patient that this is our standard of treatment, this is the standard antibiotic we give for skin microflora, and trialing it. If the patient is truly concerned, they can actually get like kind of pre-testing and just see if they're actually allergic to ANSEF. Dr. Faring, I think you're muted.
Yeah, this is Chris Polk ID. I'm not sure if y'all can hear me or not.
Yes, Dr. Polk.
Okay, I was just going to tag on to that a little bit. You're right. True pen allergies are much less common than thought. Cross-reactivity with cephalosporins is pretty low, probably less than 5%. And so taking a good history is probably important. If someone isn't anaphylactic or doesn't give a history of lip swelling and just has a childhood allergy, you may be able to proceed. Sean Boger has also worked with a nice pre-op, both desensitization and penicillin testing algorithm he's trying to roll out. So hopefully that's helpful and maybe eliminate some of the issues going forward.
Yeah, one of the reasons I brought this up, Catherine, is there's some big data studies that compared cephalosporins to vancomycin, which is usually our alternative. And the infection rate is significantly higher in the vancomycin treated patients. And also the other alternative for vancomycin is clindamycin. Another big data study showed that vanc is a better alternative than clindamycin in most centers around the country where the study was done. So I've taken to, if I have somebody who I interrogate, I'm not really sure whether it's a real allergy, I send them to an allergist for penicillin testing so they can get the advantage of a cephalosporin without the risk.